Dr. Michael Schweitzer would like to thank SAGES for inviting me to the first virtual conference. I'm going to talk about enhanced recovery after bariatric surgery. Disclosures, I have no disclosures. So enhanced recovery after surgery, ERAS was first introduced in the late 1990s. It was successfully implemented with a variety of specialties, especially colorectal surgery. ERAS pathways are to help maintain physiologic function after surgery, enhance mobilization, reduce pain, and facilitate early oral nutrition. The ERAS Society published guidelines back in 2016. Some of the recommendations: pre-op education had a moderate level of evidence with strong recommendation. Steroids, low evidence but strong recommendation. Obviously, preventing nausea is job number one after bariatric surgery. Clear fluids 2 hours before induction. They had a high level of evidence in non-diabetic patients. Again, a lot of this data was taken and extrapolated from other surgeries, such as colorectal, and not necessarily from bariatric surgery. And it had a strong recommendation. Limit perioperative fluid, moderate level of evidence, strong recommendation. Multimodal prevention of post-op nausea and vomiting, low level of evidence but strong recommendation, obviously very important in bariatric surgery. No NG tube, no JP drain. Analgesia with a tap block and medication, or IV lidocaine, high level of evidence, strong recommendation. Thromboprophylaxis, again, high level of evidence, strong recommendation. And if the patient is on CPAP at home, moderate level of evidence, strong recommendation. So carbohydrate loading had a low level of evidence for bariatric surgery patients. The recommendation, however, was strong, but that was based on non-bariatric surgery patient studies. It's hard to say whether carbohydrate loading is helpful, especially since most of us do 2-week liver shrink diets or high protein diets. It's unclear if carbohydrate loading is a good thing or a bad thing in those patients. So Dr. Brethauer did a national quality improvement project using MBS AQIP improvement program. It was called the Energy. There were 36 centers. These were high outliers for extended length of stay. Luckily, we were one of them and were able to join. It went from July 2017 to June 2018. There was a run-up period for the team to get used to the protocol, and that was between January and June of 2017. In total, there were 18,048 cases over a 24-month period. The primary outcome of interest was extended length of stay. It was defined as any hospital length of stay greater than 3 days. Secondary outcome was bleeding, readmission, and reoperation. Obviously, patient education was very important before the surgery. Opioid-sparing multimodal pain management strategies were employed. Goal-directed fluid management and minimizing insulin resistance perioperatively was important. In the Energy study, 93% of patients had 2 or more antiemetic agents. 87% had no Foley. 92% had no drain. 92% got less than 2.5 liters of fluid in the OR. 82% had a tap block or lidocaine drip. 25% of patients had no opioids after the recovery room. The extended length of stay for pre and post intervention was 8.1% and 4.5%, and that was statistically significant. There were no increases in readmission, reoperation, or overall morbidity. Bleeding rates trended up 0.8% pre-intervention and 1.1% post-intervention, with an adjusted p-value of 0.6. Again, opioid-sparing multimodal pain management strategies, including tap blocks, were used. This was shown to be significant to decrease length of stay. Meds for preventing nausea, avoiding catheter and drains, minimizing fluid overload, and early ambulation and oral intake all were statistically significant, showing a decreased length of stay in this study. So the way energy looked in our hospital with the pathway, obviously there was pre-op education. This included a handout for energy. We did use a carbohydrate drink. In our patients, we used Gatorade. They got a 20-ounce bottle the night before and then did 20 ounces 2 hours prior to the arrival of surgery. I will say we do use the VisiG device for stapling and suctioning out the stomach, and we did on occasion suction out Gatorade at the time of surgery. We did not have any aspirations. Chlorhexidine antibacterial soap for the last shower prior to surgery was used, and they discontinued ACE inhibitors and ARBs 24 hours prior to surgery. We chose to give our patients Celebrex, 200 milligrams, 1 dose upon arrival that day of surgery. Your other choice was to use Toradol. Everyone got a scopolamine patch. Enoxaparin, 40 milligrams sub-Q, was injected pre-op and was also used post-op. Fasting blood sugar was checked. Patients used the bathroom to empty their bladder prior to the OR because we did not use Foley catheters. And a single dose of prophylactic antibiotic was given within 1 hour incision. For us, that was mostly a first-generation cephalosporin. Obviously, our goals intraoperatively were to avoid as much as possible IV opioids, maintain normothermia, minimize hypotension and hypoxia. We did use a top block, avoided Foley catheters and invasive lines and drains and tubes. We did not use esophageal temp probes since they can migrate down to the stomach and get stapled. The goal was to keep the patient temp greater than 36.5, which is not difficult since we're using warm humidified air for pneumoperitoneum. Intraoperative glucose control was maintained by anesthesia, and we limited the total IV fluids in most cases to less than 2.5 liters. Minimal or no induction opioids and avoiding opioids during the case as much as possible, using lipid-soluble anesthetics. Obviously, there's a strong recommendation to use total intravenous anesthesia. Vasopressor support instead of fluid to treat hypotension that was related to the anesthesia. And medications, we were able to use IV Tylenol 1 time, but we were not allowed to use it postoperatively. However, with the energy protocol, we could use PO, acetaminophen. Dexamethasone, we usually gave 8 milligrams IV on induction, and Zofran 4 milligrams, 30 minutes prior to the emergence from anesthesia. Promethazine, we did not use very often, except PRN. Post-op, again, avoid IV opioids as much as possible. Try and prevent nausea before it starts. Early ambulation, early hydration with oral liquids. Goal was to discharge on post-op day 1. Acetaminophen was used PO. We weren't able to use it IV due to the hospital's rules. Opioids were used for breakthrough pain only. We continued the scopolamine patch, and we did give Zofran. Evening of surgery, they started on liquids. We got them out of bed 2 to 4 hours after arrival on the floor. We do not do upper GI studies, and we use CPAP if it was indicated. Post-op day 1, again, continue the PO Tylenol and Celebrex 1 dose. Again, opioids for breakthrough pain. Scopolamine patch, continued Zofran. We did increase the bariatric liquid diet. The goal was 48 ounces over 2 hours. We discharged home with the dietitian seeing every patient before discharge and the nurse going over the discharge instructions. They would then get a call from our nurse the following day, and 1 week from discharge, the dietitian would call the patient. They would then follow up in 2 weeks and follow up with the dietitian within the first few weeks. We did a study based on our energy protocol and recently published in Surgical Endoscopy. Again, pre and post ERAS initiation 2015 versus 2017. Primary outcomes were length of stay and total cost. Secondary outcomes, readmissions and complications. We were able to look at cost and data from the Premier Health database. The mean length of stay reduced from 2.77 days to 1.77 days, and this was statistically significant. 50% of our patients were discharged on post-op day number 1, post-ERAS. This shows the average length of stay has carried forward even past the energy study and continues to decrease. We are now down to 1.3 days median length of stay, with most of our patients leaving on post-op day number 1. And also our 30-day readmission rate, again, this shows decreasing rates even past the energy study and now down to 6.1% in 2020. So we were able to look at cost using the Premier database, and the median cost was reduced from $11,739 to $9,482, and this was statistically significant. So this net savings of cost was over $800,000 it saved our institution. So in summary, we were able to reduce the length of stay from 2.77 to 1.77 days, and that's continued past the study. We were able to decrease the median cost, and we had no compromise in patient safety. We went from 2.17% to a 1.72% complication rate. So it actually went down, it did not go up. Conclusions, we standardized an ERAS protocol from the MBS AQIP that is both safe and effective. The cost savings and faster bed turnover is seen with no compromise in patient safety. I would like to point out the SAGES website for enhanced recovery has a lot of information that can help you get started or improve your ERAS protocol. Thank you